We are here for the next session. I'm David Cohen from St. Francis Hospital in the Cardiovascular Research Foundation. I'm the co-moderator. We're looking for Dr. Bangalore if he's here or nearby. But in the meantime, we have a panel to discuss what I think should be a really fascinating case of TAVR for pure aortic regurgitation. We have on the panel James Flaherty, Kentaro Hayashida, Hyun Kim, Euihong, Osung Kwon, Jung-Hee Lee, Michael Lee, Mao-Shin Lin, and Nikos Werner. I'm not sure I see every single person here, but hopefully the others will show up. And now we are going to Nanjing First Hospital, where Dr. Junjie Zhang is going to be leading the case. Welcome, Dr. Zhang.
Hello, Debbie. Can you hear me?
Yes, we can hear you great.
I'm Dr. Zhang from Nanjing First Hospital.
Yes, we can hear you.
Firstly, I really appreciate TCTAP invited me on behalf of Professor Cao Liangchen. Today, our team will perform a heavy case for pure AR. Firstly, let me introduce my team. On my right side is my assistant, Dr. Kong Xiangquan and Dr. Zhu Jianchen. Today's echocardiography is Dr. Juan Zhang. So, firstly, let me invite Dr. Kong to introduce the case information. Please, Dr. Kong.
Okay, thank you. Please show slide. Today, I will take a case for severe aortic regurgitation. Next. Yes, this is a 79-year-old man with normal BMI. He presents our hospital for progressive shortness of breath for 1 year and aggravate for 2 months. His comorbidity include essential hypertension and the New York Heart Association is class 3. His NT-proBNP is more than 2,100, and ACT is normal. And ACT score is 60.7. Next.
We do not hear you anymore.
Slide.
Okay, thank you. Next slide, please.
Next slide, please. Yeah. This is echo finding. From echo finding, we can find that this is a severe aortic regurgitation. And LV function is preserved and LV is dilated. Next. This is CT image. From CT image, we can find annulus angle is 62 degrees, and there is no any calcification in leaflet. And ascending aorta diameter is normal, and ascending aorta is not dilated. Next. And this is annulus average diameter is 23.4 millimeter, and LVT diameter below annulus 2 is 22.7 millimeter. Nearly the same size of LVT diameter below annulus 4 and below annulus 6 diameter. Next. This is the coronary obstruction risk access. From this slide, we can find left coronary artery is high enough and more than 11 millimeter, and the right coronary height is more than 23 millimeter. And the valve size is more than 30 millimeter, and STJ size is not enough. Next. And a near femoral artery is more than 60.7 millimeter. Yes. So today we are procedure strategy include general analysis, PE, and angio guidance, right femoral approach, and we are plan to put Vita flow self-expanding self-valve. Next. Thank you.
Thank you for Dr. Kong introduce the clinical case. So Dr. Cohen, before we discussion, I would like to invite my colleague, Dr. Zhang, to introduce today's TE echogram result.
Hello. This is the TEE images before the valve deployment. So from the short axis view of the TEE, we can see actually the aortic valve is tricuspid, and it has three cups, and the cups looks like something like degenerative, and the valve is thickened, and the leaflets, the age of the leaves, especially during the edges of the leaflets. And the tips of the tree cups shrinks, and there's mere coaptation in the central of the aortic valve. So the rectation comes out from the central part of the valves. So this is a long axis view of the aortic valve. So here we can see the stiff movement of the valves, especially in the right coronary artery cups, and the tips of the valve is thickening. And maybe the lesion due to some part of the rheumatic changes. And the aortic rectation is definitely severe and significant, yeah. And the airway function, the airway is dilated, and the muscle of the airway is thickening. So I think it is consistent with the standard and the chronic severe aortic regurgitation. And we look to the anatomic structure of the aortic root. So actually, the semi-automatic program by the machine of the 3D TEE measuring of the aortic annular diameter is about 23 millimeters, and the aortic annular circumference is 73 millimeters. And we look to the diameters of the aortic root. Here we can see the diameter of the aortic sinus is about 33 millimeters, and the STJ is about 28 millimeters, and the ascending aorta is about 35 millimeters, and all these are not dilated. So I think it is quite suitable for the self-expanding TAVI valve, because the muscle of the LOVT is quite strong and bulgy to the left ventricular side, and this side can actually can prevent the valve slide to the left side ventricular, and the not dilated super valve structure can hold on the whole system, can hold on the whole valve. So I think it is a good candidate from the echo to do the procedure. Thank you.
Thank you, Dr. Zhang, for your introduction of echo information. So, Dr. Cohen, so this is clinical information. This is the elderly patient presented with heart failure. Echo shows severe aortic regurgitation. So there is a high risk for surgery. So there is indication for TAVI procedure. However, so far in mainland China, there is no dedicated AR TAVI valve. So for this particular case, according to the CT analysis, decision was to made. We will use domestic Vita Flow second generation THV self-expanding valve for this particular pure AR case. So I would like for your option and the suggestion for this case.
Well, thank you very much for going over all the information. Obviously, I think in my mind, if I had a choice of all the different tools that are available today, including ones that are investigational, I would love to use a Jena valve or a J valve for this, because they are built for this anatomy. But right now, those are still investigational in the United States, and I understand perhaps the same in China. But I would like to hear from any of the panelists thoughts about how would you choose between a self-expanding valve versus a balloon expandable valve in this case?
Well, I think that the advantage of the self-expanding And the model they showed is that it can anchor at more than one place. You have 0 calcium here. The big fear is migration and paravalvular leak. When you can choose a valve that's going to anchor in 2 to 3 spots, that might give you a little more stability. Now, of course, you have to oversize by at least 20% to get it, enough contact.
So we don't obviously in the U.S. have access to this particular valve that you're planning on using. We have core valve Evolute. What size would you choose here? Would you choose a 29? Would you think it was I think the perimeter was about 70 or so?
I think you'd probably have to.
Yeah, I mean, any other thoughts, Kentaro? Do you, how would you be treating this in Japan if you didn't want to do surgery?
So actually, this AR is not indicated for the TAVI procedure in the country. We always send this kind of case to surgery. And when I was a fellow in France, we used to use core valve. Then we have some case of embolization, so we should be careful.
Yeah, I think it always makes you nervous, and it's why we really need the purpose-built valves for this. Any other thoughts?
As I know that the J-valve has a commercialized use in mainland China, although it's a transapical device.
Not yet.
Transapical.
I think they finished the
transapical.
clinical trial waiting for the results. Oh, transapical then.
Yeah, transapical is surgery. You might as well just do surgery, I think. So why don't you go ahead and let us know what you're doing and explain the device to us? I see is that a snare? Like, what's that about? Help us.
And they don't have dedicated shaded wire as well.
Oh, okay.
They have to use. Junjie, this is Michael speaking. What wire is this?
Landerquist wire.
Landerquist, okay.
Landerquist wire.
So you don't have the pre-shaped wire, am I right? You don't have the Safari. You don't have the...
For pure AR case, I prefer Landerquist wire to the pre-shaped wire because Landerquist wire can give more support. When I deploy the valve, I will get more support from the wire, avoiding the valve diving. So for the pure AR case, I always use the Landerquist wire.
And we see the snare as well.
Yeah, what's that about? Yeah, I'm trying to figure that part out.
Yeah, there is a snare in case, I think, because sometimes you can see the aortic angle is quite large, more than 65 degrees.
That's right.
So when we deploy the valve, coaxial is always important. So I always prepare the snare in case maybe snare will facilitate the THV system to occur.
So that's specifically because of the horizontal aorta is why you're using the snare? Or would it be all cases?
Yeah. So I will snare standby, yeah.
Okay.
And also you can see the aortic arc is, the angle is not so wide. So in case prevent the injury of the aortic ascending aorta, I will always use snare. So this is why I always use snare standby. So my distinguished panels, so I inserted the VitaFlow second generation self-healing valve into the body. Actually, this case is also enrolled our season AR trial, randomized into the TAVI group. This trial is also the first randomized trial. Totally, we tried to include 210 severe AR cases with RV dysfunction and also with high risk for surgery. Then one-to-one randomized either to GDMT or GDMT2 TAVI procedure. This particular patient was randomized to TAVI procedure.
So you're running a...
Now I advance the valve.
So the patients in that trial are all high risk? That's for surgery? That's the group that you're randomizing?
Yeah. High
Amazing.
risk for surgery, then randomized.
It sounds like this is a study patient.
He is, yeah. He said he randomized the device.
Yeah.
Well, thank you for sharing this with us. It's really great.
Yeah. Okay. Let's go to the AP caudal for the valve deploy.
So you use a similar cusp overlap technique as we use for all self-expanding now? Yep.
Okay. Now I put the pigtail at the non-cusp. Okay. Then I advance the valve, 顶档式. Okay, good. 不要太紧. Okay. Okay, let's take a picture. Okay. So, 顶住啊.
准备起搏准
So
备
you。don't need the pacing?
Yeah.
Yeah.
When I deployed, we will need a pacing, 140, something like that.
Yeah.
Pacing, start pacing, 140, 140.
Okay.
释放。没把我起过。噪音。怎么样？位置
挺好的
怎么样？，
挺好的。
有把头了啊，
什么？放吗？
Pretty high position.
导丝要顶一点，
顶住，不要顶，顶住。
稍微顶一点，导丝要稍微顶一点。
放吗？
放完，
放。
导丝要稍微顶一点。
谢谢。
导丝要稍微顶一点。好，OK。
Okay, I stop pacing. 90.
Very stable.
70. So I have deployed the valve. So can you see the echo?
We do see the echo. Yeah, we see the fluoro and the echo and the hemodynamics all.
Okay, please put the echo in the main screen.
Looks like it landed nicely.
Yeah, I mean, we never went back over to LAO, but certainly the non-coronary cusp looks
回到左前线，
perfect.
不要拔。
Now we're at LAO.
There you go.
Oh, I see.
小心啊！引导式，引导式。
导丝不要再顶了。
不
Okay.
顶了。
Pressure's coming up slowly.
Yeah，
活跃加快。
我也加快。位置好吗？
好的，
有没有跳上来？
没有。
Okay, good. Epicaudal. BP is up.
稳定住了，因为它时间隔着没什么锚定。
So I have successfully deployed the valve. So Dr. Zhang Jian, can you introduce the echo result? Please put the echo information in the bigger screen. Yeah.
Okay. After the valve deployment, we can see the valve is quite stable, and the valve function is good, and there's definitely no perivalvular leak. So I think it is a perfect result. Yeah.
Now it looks, I mean, the depth looks perfect. It's really just at the, at the edge of the mitral valve. It's not really impinging on the mitral at all.
Yeah.
And I didn't see any AR. Anybody see AR?
Maybe trivial,
Oh, yeah.
but that's.
So why don't you have a picture, the scene?
Yeah,
The
just
contrast,
1
yeah.
minute. Because the iliac artery the size is not so enough, so I use the inner sheath. So now I have pull out the whole system, insert the sheath. Now I will take a picture.
So do you usually leave pictet catheter?
Yeah, after TAVR procedure, I always leave the pigtail.
Even for pure AR?
Maintain, maybe 15 minutes in case the valve later malposition or diving or pumping out. But for this particular case, according to the baseline CT analysis, we select 27 millimeter self-expanding beta flow valve. The overall size ratio is 1.12. I think it's enough for this particular case.
起搏多少？现在起搏多少？
Does this valve deploy very much like a Evolute valve? Is it recapturable up to a certain point in the deployment?
Yes, actually it's a domestic valve. It's also second generation, can be retrievable and recaptured.
And does it the valve start to function once you're about 70 or 80% deployed?
Yeah, can be retrieved at the before the fully deployed.
Is it with the motorized drive system, Junjie?
Yes.
Yeah, good.
Yeah, Michael. This Vita Flow second generation is a motor device, can be automatically deployed and retrieved.
Is that what you were using?
Yes.
Oh, okay. I didn't appreciate that.
Yeah, I didn't see the
So was the
hands.
motor.
Yeah,
So
no, it looks,
I can show you the
was
motor
very
device
consistent.
of the valve.
yeah,
Just went with it.
I guess that's the way it goes. Yeah, the
Um,
hemodynamics look fantastic.
Yes.
LV-EDP very low.
Yeah. There is a left bundle branch block. I think for this particular case, because I implantation 4 millimeter, maybe for our experience, the pacemaker implantation after pure AR heavy procedure is 20%.
So will you leave the pacemaker in tonight? The temporary pacemaker?
Yeah, fine. You see the result is good without any PVR. The valve is stable.
So what percentage of your TAVR procedures are done for pure AR?
40%.
40.
Actually, in mainland China, the prevalence of AR is totally different to West country. I think the main reason is, hypertension. It's not so good control. So for elder patients, according to our China DVD register, the moderate to severe AR is two-folds of moderate to severe AS.
Wow. So that is very, very different
Yeah,
in
because
Western countries.
we would struggle to do a study like this,
Yeah.
just to recruit the numbers that they're getting.
Yeah.
Yeah, for sure. You know, again, I think, we would be nervous every time we treated one of these because we don't have, the experience you do. So it's great to benefit from your experience. And clearly you have no problems with treating these patients. Do you anticipate when you will have dedicated devices that you will switch over, or do you think you will continue to use self-expanding valves very frequently?
Yeah, very good questions. So far, according to our limited experience, for aneurysm diameter less than 25 or paradiameter less than 85 millimeter, I think the off-label use Vita Flow secondary valve is feasible. But for large aneurysms, the diameter aneurysm more than 27, I think after the dedicated valve, like Euihong valve, like J valve transfemoral approach edition, if available, I will use.
No, I think that's a great point. And we, again, certainly in the U.S., we look forward to having the Euihong valve fairly soon. Completed its FDA trial, and we're just getting ready to start the pivotal trial for the J valve, also the transfemoral J valve. So I think we will have tools, but we don't have the patients like you do. I mean, it's a much smaller group of patients in the United States. Any comments from the panel on the technique or the device or the patient?
Junjie, I'm Dr. Mao-Shin from Taiwan. We know that the current TAVR device in the pure AR, sometimes we have a delayed malposition. So if you have any tip and trick to keep that less than days risk?
Yeah, a very good question, Mao-Shin. I think the most important thing is baseline CT analysis. According to our experience, for pure AR with off-label use SEV, there are at least 2 anchoring zones. For this particular case, annular and also the LVOT is supply 2 anchoring zones. So at least 2. And the oversize ratio should at least 1.1 for me experience. And also after procedure, so far we don't have experience of a later malposition of the valve, but we should control the BP. Control the BP less than 120, something like that. Yeah.
I mean, this patient is 79, I think, right? They were
Yes.
fairly old for that. Are you treating young patients also this way, or only patients who are not good surgical candidates?
Yeah, if we only treated the patient, pure AR, with a high risk of surgery.
Okay.
Yeah. If the moderate or low risk, we definitely refer the patient to the surgery. So that's why we designed the season AR trial. So we only included the high risk surgeries.
So let me just ask about this trial, because I was not aware of the trial at all. First time I've heard of it. So you said it's about, I think, 200 patients you're going to randomize, and they're patients who are high risk AR, I assume with symptoms or LV dilation, and comparing TAVR versus medical therapy. Is that correct?
That's right, Dr. Cohen. So we totally try to include 210 cases with severe AR, with heart failure, with a high risk of surgery. So far, we have included 135 patients.
Fantastic.
Maybe up to next year, June, we have completed all the patient enrollment.
That's very exciting. And what is the primary endpoint?
Primary endpoint is a 1-year composite endpoint, including, of course, mortality, ischemia, stroke, and heart failure hospitalization.
Wonderful. So it's really a great informative study. Well, I'm going to just take my prerogative and say we would love to have your study presented at the New York Valves meeting next year, if it's possible, or the year after that. Just put that thought in your mind. It would be enormously exciting for us. So I hope you'll be able to share it with us, but I know it'll be shared somewhere.
Thank you very much.
Junjie, we were discussing which valve to choose. Do you have balloon expandable valve in your center? Or you use self-expanding valve all the time for pure AR?
Yeah, Michael, in our center, I only use, we have a SAPIN, but for pure AR, I only use a self-expanding valve.
And is there a particular self-expanding valve that would most suitable for the AR?
Yeah, actually, so far there is several dedicated AR valve transformer edition, but all is trial ongoing. We just completed the enrollment of the inner valve Chinese edition, and also Cohen has a dedicated valve, and also a J valve transformer approach. Maybe next year will be approved in mainland China. Yeah.
I mean, do you see so much aortic regurgitation in Taiwan? Who's in Taiwan? Actually, I'm sorry, it's not here. Right?
Mao-Shin is from there.
Yeah, I think that's
Similar?
similar.
We don't see that many in Hong Kong. Hong Kong. Yeah.
So Hong Kong is more Western somehow. It must have been infectious in some ways. Anybody else seeing lots of AR?
No, in Germany we see it very rarely. And when we see it, we have really large anatomies. So this is our main problem for treating AR, that most of the valves are too large for treating with a TAVR, with a commercially available TAVR valve. So we sometimes implant a balloon expandable Merrill valve because you can get it in larger sizes. But this is or Jena valve, but they have a problem with valve availability at the moment.
Yeah.
So I would be very interested in what is your preferred oversizing for the self-expanding valves. What do you choose? 20% at least, or are you going even larger? What is your preferred oversizing?
At the beginning, I think 3 years ago, I will use at least 1.20 oversizing index. With the experience now, for this particular case, the oversizing ratio only 1.12. So avoiding the high rate of pacemaker implantation.
That's very, very helpful. Again, I think for most of us who, again, do not treat this very often, it's wonderful to have your depth of experience with the different devices. Does it, other than the fact that this patient was in the trial, you have several different self-expanding valves. I think you have the Evolute, I assume. I think you have a venous valve, which is similar, also in China, perhaps. Do you have a preferred one, or any one that fits the anatomy is okay for you?
For season air trials, the only valve we used is a Beta Flow. Actually, although there is several brands of Cervix valve, but VitaFlow, so far to my knowledge, is suitable for the AR case because the design is the inflow is tubular. It's tubular.
Yeah.
Actually, there is no waste. Will be facility for the anchoring, especially for the aneurysm and the LVOT. So for CDN AR, the dedicated valve is only we use VitaFlow second generation valve.
So the tubular aspect is something you prefer.
Visually, this looks a little thicker than the Evolut profile.
Yeah, I mean, the Evolute comes in at the
Conical.
neck, yeah.
Yeah.
So I think that does, it certainly fits my eye better at the very
Because honestly, if
the
you
very
could
least.
get these results, this is a great result.
It is. No, it wouldn't, again, if we knew how to do this, we would do it.
Yeah.
I think, or if we had this, this particular device, so
They
it's,
did it in 5 minutes.
no, it's, well,
David, can I ask a question?
sorry, go ahead, Kentaro.
So, and I'm Kentaro from Keio University, Tokyo, and congratulations on your great result. So could you please tell us your tips and tricks to avoid embolization in case of the pure AR?
Yeah, thank you. It's very important questions. For me, I think the first important thing is use the TE guidance. So for AS case, we will use conscious sedation with TTE, but for pure AR case, in our lab, I think we always use general anesthesia and with the TE guidance because TE, online TE can supply the more precise information, especially the valve deployment. The second is we always use rapid pacing. And the third is during deployed, I will decrease the ventilation of to maybe 200 milliliter to reduce the ventilation impact of the valve stabilization.
I'm sorry, I want to make sure, so you said you bring the blood pressure down? Is that what was it describing?
Tidal volume.
Tidal volume, oh, okay. So like we do sometimes in the mitrals and tricuspids.
Yes,
I didn't realize you were deploying this mostly based on the TE guidance. I have to say we've lost that art, I suspect, very much, and that's a very good, good and important lesson for us. So thank you for that. Are there any other questions from either the audience or the panel? Do you want to finish up? It looks like you're all done. Do you have more that you want to show or complete? Should you do an aortogram, perhaps?
Okay.
There's a lecture. I'm sorry, I didn't even realize.
Another 15 minutes has passed. So I'll do the final angiogram.
And then, okay, great. And then are you giving a lecture after that?
It's recorded.
Yeah, that is a recording.
Oh, okay, wonderful.
Please
Okay.
pull the
Thank you.
rope up. Let me take a picture.
Too many assignments.
Yeah, the valve is stable. Good position. Yeah. Thank you very much.
Yeah, thank you. Thank you. A wonderful demonstration.
Session. Thank you so much. Maybe in the near future we can meet in person.
Thank you. We look forward to it. So now let's go to the lecture.
I'm Dr. Junjie Zhang from Nanjing First Hospital of China. It's my great honor to participate AP Valve conference. Today's my topic is early multi-center experience in treating severe aortic regurgitation. Use self-expanding valves. CDN-AR regesture. I have nothing to disclose. Annual mortality rate is correlated with NYHA functional class in patients with severe chronic aortic regurgitation. According to ESC guidelines, patients with severe with a symptom or LVEF less than 50% or LVESD more than 50 millimeter will be referred for surgery aortic valve replacement. However, among daily practice, patients with severe native AR, only 21% with LVEF between 30 to 50%, and 2.7% with LVEF less than 30% will refer for surgery aortic valve replacement. Advanced age and comorbidities were often given as reasons not to offer SAVA. The annual mortality of untreated patients with severe AR is up to 20%. Different to aortic stenosis, challenges of AR for pure native AR were mainly due to unfriendly anatomic aortic characteristic, like large aortic sinus or annuli, and also dilated aortic ascending aorta, which were resulting in insufficient anchoring, which were resulting TAHV migration or embolization, and also with a radial PVL, and also increased the high rate of pacemaker implantation. With available of the second generation TH valve, the successful rate of the TAVR procedure for AR was significantly increased compared with the older generation. Also with a lower rate of valve-in-valve and the lower rate of PVL, and also the lower rate of mortality. Let me show you one case. This was an 85 gentleman presented with a heart failure. Echocardiography showed severe AR with a poor LV function, EVF only 32%. Considering it's a high risk for surgery, so decision was to perform TAVR for this particular case. CT analysis showed this patient aneurysm of aorta diameter was 29. Decision was to select the TONAS trial 27 TH valve for this particular case with the oversize ratio 1.03. This case was enrolled to Chinese pivotal trial of TONAS trial valve. With the TE guidance, we successfully implanted the TONAS 27 mm valve for this particular case. So far, there are 7 brands of dedicated transfemoral TH valve for pure AR in China. All these pivotal trials are ongoing, including TONAS trial valve, Pioneer valve, and the J valve. All these dedicated valve is from the femoral approach. So far, in China, there were no commercial dedicated valve for pure AR. So for daily practice, how to treat this high-risk surgery patient with a severe AR? This was a 79 gentleman also presented with a heart failure. Echocardiography shows severe AR with a reduced LV function. CT analysis shows the aneurysm diameter was 26 millimeter. And also you can see the ascending aorta is normal. The diameter was 35 millimeter. Decision was to make to select the VitaFlow 2 second generation 30 millimeter THV for this particular case with oversize ratio 1.11. With the TE guidance, we successfully implanted VitaFlow 2 30 millimeter for this pure AR case. The third case is also a live case from the Jung-Hee Valve 2024 conference. This was a 71 female with a low body weight presented with heart failure. Echo shows severe AR with a poor LV function, LVEF only 27%. it's high risk for surgery. So CT analysis shows the aneurysm diameter was 24.8 millimeter. And also this Vasava is not so large, only 29 millimeter. And the left main high only 9.8 millimeter. So after CT analysis, decision was to select the beta flow 27 millimeter for this particular case with oversighting index 1.06. This case, we also use a general analysis with the TE guidance. We successfully implant beta flow 27 THV for this case. This is the final result of the aortic root angle and the TE. You can see the valve was successfully implanted. CDAR trial was organized by Professor Xiaoliang and me, included 2 arms. Today I will report the reduced arm, patient with POAR who underwent TAVR in 5 centers from mainland China from September 2019 to February 2020. All these 79 patients received 6 months clinical follow-up. Another group is a randomized group. Totally, we were included 210 patients with severe AR, which was also high risk for surgery, were randomized either to TAVR procedure or medicine therapy. CDNR register, we included a patient with POAR with heart failure, underwent transfemoral TAVR procedure, were registered at 5 Chinese centers. 2 self-extendable TH valves were used in CDNR register. One is Vita Flow, another is Venus A valve. The primary endpoint was device success at 30 days. Secondary endpoints including MACE at 6 months after TAVR, defined as composite of all-cause death, ischemic stroke, emergency conversion to cardiosurgery, and the new pacemaker implantation according to the VAC3 criteria. Baseline clinical characteristic. The mean age of this patient was 72. Mean ST score was 6, and the LVEF from the core lab was 52%. Pre-procedure CT analysis from the core lab show the aortic aneurysm parameter was 78 millimeter. Parameter of LVOT 4 millimeter below the aneurysm was 82 millimeter. Ascending aorta diameter was 40 millimeter. Aortic valve calcium was only 6 millimeter. Interim procedural characteristic. All these 79 patients received general anesthesia, received TE guidance. All the cases we performed from the transfemoral approach. Among the valve we used, 80% of valve was the first generation. It's a non-recapture valve. Only 20% of valve was second generation valve. The oversize index was 15%. 56 cases received the largest valve, including Vita Flow 30 or Venus A 32. Procedural complication. Of-cause mortality, only 1 case. 19 cases used the second valve, valve-in-valve. Most of was used the early generation. Only 1 case we will use a second valve in new generation valve. 2 cases were transferred to emergency cardiosurgeon. New pacemaker implantation rate was 27%. Majority were due to the high degree of ABB. At 6 follow-up, MACE rate was 36, mainly driven by high rate of new pacemaker implantation, 31%. With a multivariable logistic regression, we find 2 predictors of device success at 30 days. One is ST score, another is aneurysm parameter. We use RC curve to detect the aneurysm parameter, predicting the device success. The cutoff value of aneurysm was 80.2 millimeter. Sensitivity was 68%. Specificity was 65%. At 6 months follow-up, small aneurysm group defined as aneurysm diameter parameter less than 80 millimeter was associated with significantly lower rate of MACE, 26% versus 50% in big aneurysm diameter. Among 78 patients, 42 patients got 6 months TE follow-up, compared with baseline TE. At 6 months follow-up, patient was associated with significantly improved LVEF 58 compared with the baseline 52, and also with a significantly lower decreased left ventricular mass index 160 versus baseline 161. Season Air registry article was published in Cardiology Discovery 2023. The Season Air randomized trial arm is ongoing. Totally, we try to include 210 patients with a severe AR, with a heart failure, also with a high risk of surgery, which was randomized either to a TAVR group or GDMT group. The primary endpoint was a 1-year composite endpoint, including all-cause mortality, disabling stroke, and the rehospitalization for heart failure. Up to date, 132 patients had been enrolled. The protocol of Season AR randomized trial was published in AHJ 2024. Ladies and gentlemen, let's take conclusion. Transfemoral TAVR with expanding valve could be considered an option in pure severe AR patients, not suitable for surgery, with acceptable device success and increased new pacemaker implantation rate, and also improved LV function after TAVR procedure. Device success and clinical efficacy could be improved significantly in AR patients with average aneurysm parameter. Season AR randomized trial is ongoing to demonstrate the benefit of TAVR for pure AR with high risk for surgery. Of course, the dedicated TAVR procedure, TAVR device with a transfemoral approach need to be developed for pure AR. Thanks for your attention.
Well, thank you all. I think the session is ended, and I wish you all a very good afternoon and safe travels home.